Yeah, so welcome to Decoding Complex PCI case 18. So today I'm bringing one recent case of mine, so in which we used one Extrastent Plaque Modification technique to expand unexpanded stent in right coronary artery. I'm Dr. Sharath, Interventional Cardiologist, Medicover Hospitals, Hyderabad. So this patient of mine is a patient with recent unstable angina, for which he underwent coronary angiogram and then had two stents placed in left antedescending artery and one stent in right coronary artery. Patient had an underexpansion of right coronary artery stent. Despite all the attempts by earlier operator, he used OPN-NC and multiple NC balloons. But he couldn't dilate as the balloons got ruptured in the course of dilatation. And he came with an acute coronary syndrome with acute inferior MI to our emergency department. And he had comorbidities of hypertension and diabetes. So when he had come to us, he came with an acute inferior MI. You can see this is the angiogram showing significant total occlusion in left circumflex, and also you can see a stent in left antedescending artery, which is well expanded and flowing nicely without any instant stenosis. You can also observe RV branches filling from left antedescending artery. So in you can see here this is the RV branch which is filling from left antedescending artery. So and these are the right injection, which clearly shows total occlusion of right coronary artery, which is the reason for his acute inferior MI. Now, you can also observe the stent. It is like an hourglass. You can see here there is a gross underexpansion of stent in the middle portion. So, and that is the reason for his total occlusion. So immediately we went ahead, we changed the guide to amplitude left, and we wide right coronary artery through the stent, and we made sure we are not through the struts. And then we did a thrombosuction. You can see after thrombosuction, so we got a good distal flow, and we can also make out the gross underexpansion of the stent here. So then we dilated with a 2.5 millimeter NC balloon. You can see here. So this is a 2.5 into 12 NC balloon. You can see here it's ruptured. You can see the contrast extravasation here. You can see here contrast will, yes. So the balloon got ruptured, and you can see here this is a gross underexpansion of the stent. So in the course of intervention, RCA re-occluded again. So it was clotting again and again as stent was grossly underexpanded. And we did an IVS to understand what is causing this underexpansion. You can see this is the distal part of the stent where it is well expanded, and there is calcium but around 180 degrees. And you can see here this is the site of unexpanded stent. To my surprise, I couldn't make out much calcium there. So I'll show you again. I couldn't make out much calcium there. Yeah, this is the site. So there is a calcium around 180 degrees. On the other side, there was no calcium. Stent is completely, unexpanded. So yeah, so this we planned to go ahead with an IVL. So we took an IVL. This is a 3 millimeter IVL. So it's a definitely small size when compared to the distal reference. But the worry was we couldn't able to make out the exact size at the site of underexpansion. Because of that, I took a undersized balloon that is 3 millimeter. If you see the size at distal reference is around 3.3 and 3.8. It's okay. So we gave almost 6 pulses, but nothing happened, so there is no expansion happened. So then I stepped into rotablation. So this is a 1.5 bar. You can see we almost burred in more than 10 to 15 cycles of more than 15 to 20 seconds, but BURR couldn't advance beyond this point because of gross under expansion of the stent probably. So at this juncture, during the course of rotablation, I lost my wire. So you can see here there is a guide catheter backed out of RCA, and wire is looped in the aorta. In the process, I lost the wire in right coronary artery also, so I have to change my guide and rewire entire right coronary artery. So you can see here now I have a JR in right coronary artery with a microcatheter, that is fine cross and workhorse wire. I tried initially to wire in a routine technique, but it didn't happen, so I had to move on to knuckle wire with a workhorse wire. So obviously knuckle wire goes through the lumen, so it won't allow your wire to go through the struts, which is paramount to do anything in such fashion. So once wire is here, we advanced microcatheter and then pull the wire back and again resent with the knuckle down. You can see here so how it has gone. So this is another uses of knuckle in a under expanded stent, or when you are crossing through the stent. So once the wire is down, we tried crossing lesion again with a 3mm balloon. So this is a 3mm balloon with a guide liner. Of course, it didn't cross stent. At this stage, with the decision to move on to another technique to modify the plaque. So this is basically knuckling into the extra stent plaque with a pilot wire to modify the plaque. So what we did, we took a double lumen catheter. So we placed double lumen catheter over the wire. So here, then I took a pilot wire. So this is a pilot wire. So advanced pilot wire in through the stent strut into the subintimal space, and then we post it to form a knuckle. So you can see here. So when you are advancing wire into subintimal extra stent space, make sure you are visualizing it in two orthogonal views, and then we further advance that knuckle till the distal end of the stent under expansion. So don't advance knuckle beyond the stent distal edge. So that is very important. So you can see here we represented it in a graphic. So now this is a double lumen catheter, this is a pilot wire, so which we have sent just before the under expansion into the extra stent space, and then we advance knuckle beyond the distal extent of under expansion, and this knuckle shouldn't cross the distal edge of the stent. So we are essentially modifying the plaque where we wanted it. So if you go beyond the distal edge of the stent, so we may end up in a subintimal space, and which may collapse your distal lumen. So these cautions has to be followed while doing this maneuver. So what happened next is, so through this double lumen catheter, I advanced a buddy wire into the distal vessel, and then we took a 3 into 12 mm balloon, which just went down, and then we dilated that area. You can see how easily it is getting dilated. So the under expanded stent got dilated without much resistance after plaque modification with knuckle. So then I took a 3.5 OPN-NC. You can see here, so it got completely dilated. So there was no resistance at all in the course of dilatation also, which I used to feel in the beginning of the procedure. So then we stunted a whole vessel covering a distal lesion here with the 438 and 428 stunts. Essentially I have to took another stunt here because I did a rotablation and we did Extrastent Plaque Modification. So we have disturbed struts here and caused a strut fracture, which we have visualized in IVUS. That's the reason we decided to cover even proximal with another stunt, 4x28. So, and these sizes are chosen based on IVUS. And you can see this is the final result. So we had a good stunt expansion and with a nice lumen throughout right coronary artery, mid right coronary artery, and you can see in the other view also the well expanded stents and good luminal gain at the site of previous under expansion. And if you see IVUS post final IVUS, this is the distal reference, which is 11.5 here, and here it's almost 12.5, so at the distal end of the stunt. And this is the MSA, narrowest area of stunt, which is around 10.5. It's a very good area, and this is at the proximal edge of the stunt, which is around 14 mm square. So we had good luminal areas. So anything beyond 10 is, of course, the restenosis and stunt thrombosis is very, very minimal. So as we see in even left main coronary artery. So coming to the learnings from this case, so adequate block preparation is paramount in fibrocalcific lesions before deploying stunt. After deployment of stunt, under expansion minimizes further interventional options. Extrastent plaque modification with a knuckle wire is one therapeutic option if other methods like rotablation or OPN-NC or IVL doesn't work, or in an experienced hands, even this can be used as one of the therapeutic option in such cases. But care needs to be taken with knuckle wire in such scenarios. Extrastent knuckling should be done with a protection wire in distal vessel through the stunt. So this is essentially a bailout wire if something goes wrong. So you can bail out the vessel within no time. Advance a pilot wire through the stunts immediately proximal to the under expansion. Don't go subintimally proximal to the proximal edge of the stunt. Knuckle shouldn't be advanced beyond the distal stunt edge. Preferably always end it before distal edge of the stunt. It's best to end at the distal end of under expanded stunt, but never cross distal edge of the stunt, which might lead to subintimal hematoma compromising the distal lumen. So with these cautions, knuckle can be used safely in such scenarios. Thank you.